Welcome to the Deep Dive, where we take the complexity of the material you send us and distill it into genuine, actionable insights.
Today, we are tackling something pretty massive. It's a really significant critique of the modern British healthcare system.
Yeah, we're looking at the claims made by one doctor, Dr. Kadiali Srivatsa, who essentially argues the system isn't just failing patients, it's actively creating dependency.
And more than that it fuels wealth disparity. So our mission today is to unpack these sources. They claim the system undermines patient confidence, uses fear, and contributes to this huge wealth gap.
And we'll also look at the resistance Dr. Srivatsa apparently face when trying to challenge this. We're talking about bodies like the General Medical Council, the NHS.
Right, and then how this led him to develop an AI solution, Dr. Maya. So the big question we're exploring is, how did a system meant for public health end up being seen, by this physician at least, as a machine for dependency? And can tech really fix it?
Okay, let's get into it.
So to really understand the dependency culture the sources talk about today, we actually need to go back, way back, over a century.
Because the argument is that modern medicine wasn't just, a natural evolution of science.
Not entirely, no. The claim is that it was profoundly shaped by, well, money. Big financial interests.
This is where it gets quite pointed, mentioning people like John D. Rockefeller. The idea is that wealthy individuals actively pushed healthcare in a certain direction.
That's the core assertion, that figures like Rockefeller worked quite systematically to centralize healthcare, to move it away from things like natural remedies, holistic practices.
Things that weren't easy to patent or control.
Exactly, and channel it toward synthetic drugs, big hospital systems, and crucially, centralized licensing. They wanted an industrial model, basically, one that favored their investments.
And in the U.S., the tool for this transformation was the American Medical Association, the AMA, especially after the Flexner Report in 1910. Can you remind us what that report did?
Sure. The Flexner Report looked at medical schools across the U.S. and Canada. It pushed for a very specific scientific lab-based approach.
Which sounds good on the surface.
Right, but the consequence was that schools teaching other approaches, homeopathy, naturopathy, traditional healing, they were basically labeled unscientific. Many were shut down.
So it effectively standardized medicine around one model, what we call allopathic medicine. Drugs targeting symptoms.
Precisely. And the sources argue the funding sealed the deal. Schools that took money, often from foundations like Rockefeller's, had to accept board members tied to those interests.
So you get nice buildings, top equipment, maybe great teachers.
But the curriculum itself gets skewed heavily towards pharmaceutical solutions. Train doctors primarily on drugs, and, well, drugs become their main tool.
And this shift from holistic healing to symptom management with products kicked off the financialization of healthcare.
Absolutely. Just look at the costs. The U.S. spends, what, over $8,000 per person per year? Compare that to maybe $10 in some poorer nations.
And the outcomes don't even match the spending, right? Lower life expectancy in the U.S. compared to many other wealthy countries, higher infant mortality.
The sources argue this profit-driven model is structurally flawed. It's not prioritizing actual health outcomes.
And you see it in hospitals, too. The shift from maybe a philanthropic mission to a corporate one.
Where every little thing gets itemized. A tissue, a plastic cup, it all goes on the bill. Dr. Srivatsa apparently saw this accelerating back in the 80s. Doctors increasing costs, accumulating wealth.
And this directly fed into disparity.
Yes, because if wealthier patients start demanding lots of tests, maybe unnecessary ones, it pushes up the baseline cost for everyone.
Meaning poorer patients, the ones who genuinely need a basic scan or blood test, suddenly find it harder to afford. It weaves inequality right into the fabric of care.
That's the argument. Financial disparity baked into medical practice. Hashtag 1.2. Fear, loss of confidence, and the birth of dependency culture.
Okay, so we have this financial structure. Now let's talk about the psychological side. The sources highlight fear.
This is a really provocative claim. The argument is that the medical profession, as it's currently set up, kind of needs fear to maintain control.
How so? How does it inflict fear?
Well, by fostering uncertainty and discouraging patients from questioning things. People become afraid to challenge a doctor, even if they have doubts.
Afraid of that.
Afraid of getting worse care, maybe. Afraid the doctor won't tell them the truth about mistakes or about alternative treatments a colleague might offer. So they stay silent. And that silence, that's the control mechanism.
And this ties into the breakdown of the doctor-patient relationship itself.
Definitely. Think about taking a patient's history. Ideally, it's about listening, understanding their story, But the sources claim it's becoming more about ticking boxes on a protocol sheet.
Driven by efficiency or maybe legal cover?
Probably both.
This.
But imagine being the patient. The doctor's barely making eye contact, just filling out a form or typing into a computer. You immediately feel they aren't really listening to your unique problem.
And that erodes trust. Confidence just evaporates.
Exactly. Which leads directly to what Dr. Srivatsa calls the "you are the doctor's" syndrome. This is the heart of the dependency culture.
Explain that syndrome. How does it develop?
It starts young, apparently.
Yeah.
Parents rushing kids to the doctor for every little sniffle or mild fever. The lesson learned is, you can't handle this yourself, you always need an expert.
Even for things that would resolve on their own.
Right. So these kids grow up, and when they're adults, facing a health issue and maybe a doctor asks their opinion, their default response is, "You're the doctor, you tell me." They've outsourced their own bodily knowledge and autonomy.
And the irony, the sources point out, is that these same people might later get labeled hypochondriacs by the very system that trained them to be dependent consumers of healthcare.
It's a vicious cycle, and fear is the engine driving its cost. This brings us to defensive medicine.
Ah, yes. Doctors ordering extra tests and procedures.
Not necessarily because they think the patient needs them clinically, but because they're afraid of getting sued if they miss something, however unlikely. Fear of litigation.
And the cost of this fear-driven testing is huge, isn't it?
Staggering. The sources estimate around $46 billion a year just in the U.S. Billions spent on unnecessary procedures simply to protect the doctor.
And that cost gets passed on, hiking up premiums and prices for everyone, worsening the disparity between those who can afford that safety buffer and those who can't.
It connects fear, waste, and financial inequality directly.
So this drive for standardization and efficiency using protocols, the sources argue it creates another major problem. It actually undermines good clinical thinking.
Yeah, the claim is there's this strong push in modern medicine telling doctors not to think too independently. Follow the checklist. Stick to the evidence-based guidelines.
But surely protocols are meant to improve care, make it consistent.
That's the intention. But the reality, according to these sources, can be the opposite. Medicine isn't always black and white. Patients are complex. Tests aren't perfect.
So forcing everyone down the same pathway can lead to mistakes.
It can constrain thinking, especially with unusual cases. And it makes doctors more vulnerable to cognitive biases.
Okay, the sources mention two specific biases: anchoring and confirmation bias. Can you break those down?
Sure. Anchoring is when a doctor latches onto the first plausible diagnosis, maybe the one that pops up first on their checklist, and then fails to really consider other possibilities.
Like seeing a headache during flu season and just assuming it's flu, potentially missing something rarer but more serious.
Exactly. And then confirmation bias kicks in. The doctor starts unconsciously looking for evidence that confirms their initial idea and ignoring facts that don't fit.
Which can lead to the wrong diagnosis, wrong treatment, dangerous delays.
Yes. And this is where the critique gets really sharp. The sources argue that rigidly following these protocols, these evidence-based guidelines, can actually be unethical.
Unethical? How?
Because the guidelines themselves aren't perfect. The sources use the term vedavakyam, like divine text that must be followed, saying guidelines are not that. They suggest guidelines might only be 60–70% correct.
So if you follow them blindly, you're almost guaranteed to misdiagnose a significant chunk of patients.
That's the implication. And Dr. Srivatsa apparently found this deeply upsetting, seeing people suffer because they trusted doctors who were, perhaps unintentionally, providing substandard and unethical care by sticking too rigidly to flawed systems.
It suggests patients need to be more skeptical, more questioning.
Definitely. To see protocols as maybe a guide, but not the absolute truth. #tag 2.2, the global threat of antimicrobial resistance, AMR.
Okay, if rigid protocols can harm individuals, the systemic issues take on a much bigger, scarier dimension when we talk about antimicrobial resistance AMR.
Yeah, the sources don't mince words here. They call the superbug crisis a silent holocaust.
The scale of the threat described is, well, it's terrifying. They claim AMR infections could be 20 times worse than the entire COVID-19 pandemic.
We're talking infections potentially as deadly as Ebola, but spreading much more easily.
And spreading how?
Through almost anything. Food, water, the air, insects. And worryingly through asymptomatic carriers, including healthcare staff and even contaminated hospital equipment. Our hospitals become hotspots.
And the cause is clear, isn't it? Our overuse of antibiotics.
Absolutely. Doctors prescribing them for viruses like the common cold, where they do nothing, and the massive use in agriculture, giving them to livestock.
It creates this intense pressure, selecting for bacteria that can survive the drugs.
Until you end up with strains resistant to pretty much everything we have. Dr. Srivatsa apparently had a personal, shocking experience with this back in 1989.
What happened? The specific stories often make it clear.
He saw MRSA, that's methicillin-resistant Staph aureus, kill a healthy teenager in just 8 hours. 8 hours.
Wow.
And what was striking, highlighting the denial the sources allege, was that established doctors at the time apparently didn't believe him. They dismissed this incredibly resistant bacteria as some kind of fluke.
That shows incredible institutional inertia, and the sources also point fingers at the pharmaceutical industry.
Yes, the accusation is that drug companies are dragging their feet on developing new antibiotics.
Why would they do that?
Well, think about it. Antibiotics cure you. You take them for a week or two, then you stop. They're not as profitable as drugs people take for life, for high blood pressure, diabetes, that sort of thing.
So the claim is profit motives are hindering the search for cures to this massive global threat.
That's the suggestion. The pipeline for new antibiotics is running dry while the threat escalates. If we lose effective antibiotics, basic medicine gets thrown back decades. Surgeries, transplants, chemo, they all rely on controlling infection. Hashtag 2.3, the dangers of nurse prescribing and clinical inexperience.
So we have flawed reasoning, a looming superbug crisis, and then the sources add another layer of risk, using staff without sufficient clinical depth for complex tasks.
Yeah, this relates to Dr. Srivatsa's direct challenge to the General Medical Council, the GMC, the UK's doctor regulator.
What was his specific complaint?
He argued against allowing nurses who have significantly less diagnostic training than doctors to independently diagnose and prescribe medications, especially in unsupervised settings like walk-in clinics. He apparently called it quackery.
Strong words. But is this happening because the system, like the NHS, is just stretched too thin, trying to fill gaps?
That's the underlying context, yes. But the critique is that this lack of deep clinical experience leads to dangerous mistakes. It's not about nurses being bad. It's about the mismatch between training and responsibility.
The sources give an example, don't they?
A very disturbing one. A Pakistani woman wearing a burqa came in repeatedly 3 times with severe vomiting and abdominal pain.
Okay.
The nurse prescriber she saw apparently didn't do proper physical exams, missed the fact she was pregnant, and instead accused her of overdosing on paracetamol.
That's appalling, clinically wrong, and deeply damaging.
She ended up severely dehydrated, traumatized. The whole situation worsened significantly because the initial assessment was flawed. The sources argue this is the risk when less experienced staff rely too heavily on simplistic checklists, missing subtle clues.
So Dr. Srivatsa raised these concerns about patient safety with the GMC. How did they respond?
According to the sources, the response wasn't supportive. It was punitive. They mention another case, Dr. Smith, who faced sanctions after reporting safety issues.
So blowing the whistle led to punishment.
That's the claim. Victimization, harassment, financial ruin. The message sent is clear. Don't rock the boat. Keep quiet. Follow the protocols, even if patients are at risk.
That fear of retaliation becomes a powerful mechanism for preserving the status quo, doesn't it? Protecting the system, even at human cost.
Precisely. It creates a chilling effect on anyone thinking of speaking out.
So the pushback Dr. Srivatsa experienced wasn't just isolated incidents. It was, according to the sources, systemic opposition.
Yeah, coming from the top. The General Medical Council, the Royal Colleges that set the standards, the NHS itself, even reaching up to the UK Secretary of State.
And the core issue was their defense of the protocol-driven system.
That's the argument, that these institutions defend doctors who follow the rules, the protocols, even if doing so results in harm or, tragically, death. The system prioritizes following the process over achieving the best outcome.
And Dr. Srivatsa felt this directly.
He claims he was unlawfully removed from the performer group list, basically. Stopped from practicing in that capacity back in 2010. This was after he challenged the role of nurses in diagnosis and prescribing.
He tried to claim whistleblower protection from the GMC?
Yes, arguing he was raising serious patient safety concerns about inadequate training.
And the GMC's position?
They apparently refused, saying it wasn't within their remit. Essentially, they didn't engage with the substance of the safety concerns.
Which sends a powerful message about institutional priorities. Protect the system, not the person pointing out the cracks.
Right, and this institutional mindset, this focus on protocols over flexibility, has real financial consequences, especially for the NHS.
We touched on dependency costs earlier. How bad is it?
The sources cite a figure of £2 billion annually, spent just on common minor illnesses that shouldn't require a doctor's consultation at all.
$2 billion. That's the direct price tag of the "you are the doctor's" syndrome we talked about. People seeking reassurance for colds and minor fevers.
Which clogs up the system, makes waiting times longer for serious cases, burns out staff, and drains resources. It's completely inefficient.
And this systemic dysfunction leads to a really stark, almost philosophical point made in the sources, quoting someone saying, "I'm afraid there is no NHS."
Yeah, that's a powerful statement. What does it mean in this context?
It seems to suggest that the original vision of the NHS, the one created in 1948 based on universal access and comprehensive care, that ideal has been so eroded by dependency, bureaucracy, and perhaps financial pressures that it doesn't really exist anymore.
Or that its original form was maybe an aberration, historically speaking, and now we're seeing something else entirely. A system struggling under the weight of its own structures. Hashtag TAG 3.2 global health governance and the Tamiflu scandal.
The critique in the sources doesn't just stay within the UK, though. It extends to global health bodies, specifically questioning the World Health Organization, the WHO.
Right. The WHO is described as being, well, not really equipped for fast-moving emergencies. Underpowered.
They cite the Ebola outbreak as an example.
Yes. The claim is it took 8 months after the first cases and 5 months after public warnings were already out there for the WHO to officially declare it a public health emergency.
5 months late. In a pandemic, that's disastrous.
It points to a kind of bureaucratic slowness, a lack of agility. The sources worry that the next major outbreak could see similar delays because the structure hasn't fundamentally changed.
Which forces politicians towards drastic measures like lockdowns, maybe because the early, smarter containment options failed due to that inertia.
That's the implication, a failure of practical, timely leadership at the global level. And this connects to an even deeper problem, trusting the medical evidence itself.
This brings us to the Tamiflu controversy.
A really significant example. Tamiflu was heavily promoted and stockpiled globally during the H1N1 flu scare. But the company that made it, Roche.
They withheld data.
Apparently, yes. They withheld comprehensive clinical trial data for years. So the evidence base that governments and doctors were relying on was incomplete, potentially biased.
And it wasn't just the company. Even respected review bodies were implicated.
The Cochrane collaboration, which is usually seen as a gold standard for reviewing medical evidence, allegedly shared incomplete or misleading information that helped boost Tamiflu sales.
That's incredibly damaging. If you can't trust the evidence reviews, how can you trust evidence-based medicine?
Exactly. It undermines the entire foundation. If the evidence itself might be compromised by commercial interests or institutional failures, then doctors forced to follow protocols based only on that evidence are potentially working with flawed information.
It makes the case for needing more critical thinking, both from doctors and patients. You can't just blindly accept the official evidence.
Which leads us logically to the proposed solution. If the centralized systems, national, global, even the evidence itself are unreliable, maybe the power needs to shift somewhere else.
To the individual.
The empowered individual.
Okay, so against this backdrop of systemic failure, institutional resistance, dependency, fear, Dr. Srivatsa decided to build something new, using technology.
It started, apparently, quite practically. He developed something called the Pediatric Assessment Tool, PAT.
What was that for?
It was designed to help more junior staff, perhaps nurses in clinics, to better differentiate between common childhood infections and the really serious, potentially life-threatening ones. Just a tool to aid basic sorting.
But then came a key realization while developing these tools.
Yes. As he was working on diagnostic flowcharts, algorithms essentially, he realized something crucial. A doctor shouldn't just blindly follow an algorithm. Human illness is too varied, too dynamic.
So algorithms are bad for doctors' thinking, but maybe good for explaining the thinking.
That seems to be the paradox he embraced. He realized that while rigid algorithms constrain human judgment, an AI could potentially be built to explain the underlying logic of how a diagnosis is reached.
And that led him to use tools like ChatGPT to create Dr. Maya medical advice you access.
Exactly. He used large language models to build an AI engine that doesn't just give you a possible diagnosis. It analyzes the symptoms you input and trying to show you the process, how a doctor might think through those symptoms to arrive at different possibilities.
Oh, it's like opening up the doctor's mental playbook, making the reasoning transparent.
That's the goal.
Yeah.
Demystifying it. But the sources are careful to state, this isn't meant to replace doctors.
Right. It's an educational tool.
A sophisticated one,
Mhm.
designed to help people understand the critical first step. How do you tell if something is likely minor or potentially serious? It empowers users to make better decisions about seeking care, maybe catching things earlier.
Arming the patient with knowledge, basically. And there's a practical feature, the color coding system.
Yes, that's designed for rapid assessment. Users categorize their symptoms. Red for emergency, yellow for needing attention soon, green for likely common issues.
So you get an immediate visual sense of urgency.
Right. It helps you quickly gauge severity and decide, do I need the emergency room now, or can I manage this at home or see my GP tomorrow? It builds confidence in that initial decision-making.
And this has implications for public health, too, like during outbreaks.
Absolutely. If someone uses the tool and sees serious red symptoms suggestive of an infectious disease, Dr. Maya encourages immediate self-isolation.
That kind of rapid, informed action at the individual level could significantly slow down spread in a community, couldn't it? Something centralized systems often struggle with.
Potentially, yes. It puts some of that early containment power directly into the hands of the individual. Hashtag tag 4.2, restoring knowledge, confidence, and equity.
So, Dr. Maya isn't just about diagnosis. The ultimate aim seems much bigger, tackling the root causes of the problems we've discussed.
Yes, the sources frame empowerment itself as the cure for the dependency culture.
And how does an AI tool empower people in that way?
By pulling back the curtain, by showing the logic, demystifying the jargon, it aims to break down that illusion, the Maya, that only doctors hold the keys to health knowledge.
So people feel more confident questioning things, identifying potential errors.
Or just feeling more confident managing minor things themselves. If people understand why a cold is just a cold, maybe they won't rush to the doctor, misuse antibiotics, or feel that learned helplessness.
Which achieves two huge things at once. Reduces antibiotic misuse critical for AMR, and eases the pressure on health services like the NHS.
Exactly. It tackles that 2 billion pound wastage figure we mentioned. If people aren't dependent for every minor issue, the system has more capacity for those who are genuinely seriously ill. It breaks the cycle.
And the vision for Dr. Maya goes beyond just wealthy nations, right? It addresses the global disparities, too.
That's a key part of the mission described. The AI tool is offered free of charge, specifically aiming to help in developing nations.
Why is that so important?
Because it provides access to sophisticated diagnostic support where there might be very few doctors or resources. It can help manage basic health care, track disease outbreaks locally, and prevent people from suffering needlessly during pandemics just because they lack access to expertise.
It's aiming for a kind of democratization of medical knowledge.
It is. It's a very radical vision. And the sources state the ultimate promise, quite dramatically.
What's the final goal?
They say Dr. Maya AI is intended to revolutionize healthcare, to reduce the disparities created by, and these are their words, greedy, power-hungry elites, and ultimately to help humanity shed tears of happiness.
Tears of happiness. That's quite a statement.
It reflects the belief that arming individuals with knowledge can protect them from systemic failures, from flawed protocols, from health threats that the established powers have struggled with. It's framed as a movement towards medical independence. Hashtag tag outro.
So we've journeyed from the historical roots of modern medicine, looking at claims of financial influence creating dependency.
Through the resulting culture of fear, the problems with rigid protocols, the terrifying threat of superbugs, and the institutional resistance to change from powerful bodies like the GMC and NHS.
And we've ended with this proposed technological disruption, Dr. Maya AI. An attempt to bypass the established system by distributing diagnostic knowledge directly to the individual using AI.
It sets up a real tension. The old centralized system versus this new, decentralized AI-powered approach aimed at patient empowerment.
And the core message coming out of these sources seems to be the absolute necessity of critical thinking for everyone navigating healthcare today.
Absolutely. Cultivating skepticism, questioning claims, not just passively accepting what you're told by a system that, according to this critique, is deeply flawed and potentially dangerous. It's presented not just as helpful, but essential for personal safety.
Okay, so let's leave you, the listener, with a final thought drawing directly from the material we've explored. We're told we face an existential threat in the superbug AMR, something that might be outpacing our collective ability to fight it.
The sources paint a picture of established institutions struggling, perhaps failing, to adequately respond to this silent holocaust.
So if that's the case, what then is the responsibility, maybe even the moral obligation of the individual, now potentially empowered with tools like AI? What is your obligation to use this knowledge to protect yourself, your family, your community when the traditional guardians of health seem overwhelmed or inert?
The fight for health, it seems, might be shifting from the confines of the clinic to the screen in your hand. Transparently, freely, individually.
That was the deep dive. We'll see you next time.